This podcast is for informational and educational purposes only. It is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult their personal health care provider. From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm Steph Dewar, one of your co-hosts. I'm Vice Chair of Clinical Affairs, a member of the Division of Pediatric Hospital Medicine, and the co-director of the Pediatric Residency Training Program. Thanks for joining us today.
And I'm John Williams, Chief of the Division of Pediatric Infectious Diseases and Director of the Institute for Infection, Inflammation, and Immunity in Children. And I'm delighted to welcome our guest today, Dr. Taylor Abel. Dr. Abel is a pediatric neurosurgeon specializing in epilepsy surgery. He's the surgical director of the Pediatric Epilepsy Surgery Program at the UPMC Children's Hospital of Pittsburgh. Dr. Abel has extensively trained in neurosurgery and pediatric surgery and completed a fellowship in epilepsy surgery and deep brain stimulation. He came to the Children's Hospital of Pittsburgh to found this epilepsy surgery program. Dr. Abel, welcome to That's Pediatrics.
Thank you for having me.
So let me just first start with kind of a big picture view of maybe you could tell us about what exactly the program is in epilepsy surgery and what your group does here.
Thank you. That's a great place to start. Epilepsy is one of the most common pediatric neurologic conditions. It affects about 1% of the population at any given time. And the lifetime prevalence of epilepsy is about 1 in 26. So 1 in 26 people will have epilepsy at some point in their life. And what some people don't realize is that up to 30% of these patients don't respond to medical therapy. And so these are patients that have epilepsy and are having seizures, and despite being on having good trials of 2 medications, are still having seizures. And that's where I come in, and where our epilepsy surgery program comes in, because many of these patients would be candidates for epilepsy surgery when their medications aren't working. And given the prevalence of epilepsy and the prevalence of drug-resistant seizures, that's actually a very large amount of the population.
So that's really interesting. Before we dive a little more into the surgery part, I'm curious, are there sort of guidelines to determine when somebody has crossed that threshold from medical management is failing? You mentioned 2 medicines. Is it standard to try a couple? Is there, I imagine, a fair amount of judgment on the part of you and your neurology partners?
That's right. There's a wide range of practices when it comes to actually referring someone for an epilepsy surgery evaluation. And for a variety of reasons, access to comprehensive epilepsy care is a major issue kind of around the world. But what we do know is that once you've had a good trial of 2 anti-seizure medications, if you're still having seizures, then you're considered drug resistant. And what the literature would tell us is that trialing additional medications after that point, and often when I'm evaluating children, they're on 3 or 4 medications, we know that more medications beyond 2 often does not have a significant impact on the seizures. The other thing that's important to realize is that a lot of patients who are on these medications have side effects, and we also know that these medications can influence development. And that's something that's particularly important for us to consider in the pediatric population, because we want to do everything we can, not only to control seizures, but also to optimize development for children that where their development is being affected, not only by the seizures and the abnormal electrical activity in the brain, but also by the seizure medications.
So, so Taylor, it sounds to me from what you're saying then that most of these patients find their way to you and to your services via referral from neurology colleagues?
That's right.
Okay, so this isn't a self-referral or a referral in from a primary care provider generally.
I think it depends on where you are. In a place like Western Pennsylvania, where many children have access to a pediatric neurologist, the referrals would be from a pediatric, ideally a pediatric epileptologist, a pediatric neurologist that specializes not only in neurology but specifically in epileptology.
Gotcha.
But there's so much epilepsy that not every child with drug-resistant epilepsy will see a pediatric epileptologist.
Right.
And so one thing that sometimes I'll see children who are self-referred to my clinic for drug-resistant epilepsy, and the first thing I do is just make sure that they've seen one of our pediatric epilepsy colleagues and have had the appropriate workup to know what their options are.
I see. So this might be an excellent segue into what the next steps are then, as far as what the process is involved to proceed to some sort of surgical intervention for their seizure disorder.
Yes.
So can you talk to us a little bit about, you did mention that you would be sure that they had an adequate evaluation by an epileptologist, but then what would then be the next steps to figure out how, where, when to do this intervention?
That's a great question. It depends on what kind of epilepsy the child has. And so there are some children who have focal epilepsy, where the epilepsy is thought to originate in one lobe or one hemisphere of the brain. And those are children where the workup involves doing a 7-day prolonged EEG with very detailed neuroimaging that includes a 3 Tesla MRI and an FDG PET scan and also an ictal SPECT, which are all different, and sometimes in a MEG. And we use all of these different imaging modalities to try to pinpoint exactly where the seizures are coming from. And if we can't, when there's a brain tumor, we can pinpoint where the seizures are coming from. But with other types of pathologies, it just gives us an idea of the ballpark of where the seizures are coming from. And we're able to develop a hypothesis based on all of that non-invasive workup about where the seizures are arising from. Once we have that hypothesis, if we have 2 or 3 hypotheses, we can then test those hypotheses by placing electrodes directly into the brain using a stereotactic robot that is able to deliver electrodes with sub-millimeter accuracy that we then, by directly recording from the brain, we then test the hypotheses set by the non-invasive imaging to determine exactly where the seizures are coming from. And then if it's an area of the brain that we can remove, then we can do that either with a stereotactic laser ablation or with a more traditional epilepsy surgery resection. And so that's kind of a broad overview of the workflow for focal epilepsy. But there are also many children who have what would be called generalized or multifocal epilepsy, where we know from their EEG that their seizures, they have a more broad brain abnormality, and their seizures are coming from multiple areas. Those are children where once they're drug resistant, the strategy is not to remove part of the brain that's causing seizures, but is to change brain activity through neurostimulators. And so those children often have a more expedited workup.
So, okay, that's pretty amazing. I love, in common language, we always say, well, it's not brain surgery. Okay, that is brain surgery. So I knew that you had trained in this specific technique that I'd never heard of, stereoelectroencephalography. Is that what you're talking about with the deep brain probes that are placed by the robot? Could you talk a little more about that? That just sounds amazing that you can basically sort of figure out where you're going before you get there.
Yeah. When we're trying to figure out, the name of the game in epilepsy surgery is figuring out exactly where the seizures are coming from, and then taking that map of where the seizures are coming from and overlaying it onto a map of where all the important brain functions are. And the only way currently to reliably do that is by placing electrodes directly into the brain. And so in the United States, the way that's been done for the last 40 years traditionally is by doing a large craniotomy, taking off about half of the skull, and then placing what's called a subdural grid electrode onto the brain, onto just the brain surface, and then closing the craniotomy back up and having a patient in the epilepsy monitoring unit for about a week while you're trying to record seizures. That's the way that I was trained as a resident, but in the last 10 years in the United States, people have moved away from doing these larger craniotomies and have moved towards using this other technique called stereoelectroencephalography. People have touted that this is a new technique that's been advanced by surgical robotics and advances in neuroimaging, but the reality is that this is a technique that's been available in France since the 1950s. And the French have become very good at this technique. And so when I finished my training, I really wanted to learn stereo EEG because I had been using the grids for years as a resident. And I kind of thought, the best thing to do here would be, rather than learning from someone in the United States who's been doing it for just a few years, I'm going to move to France and learn from someone who's been doing it for longer than I've been alive. And so I moved to Grenoble with my family for about 6 months and did stereo EEG there for about 6 months, and then have started the program here. And so what stereo EEG involves is, rather than doing a large craniotomy and placing a grid of electrodes on the brain, we get really detailed neuroimaging, and then I spend about 2 to 4 hours at a computer planning these very detailed trajectories to both surface and deep brain structures. And then we put those trajectories into a robot, and we register the robot in space to the patient's brain. And then we use the robot to place these electrodes safely and accurately. And then we can record where the seizures are coming from without doing that large craniotomy.
Wow. That is an incredible description and process. And I'm wondering, what volume of patients do you impact in a year, perhaps? And what age range mostly would you say are you working with?
So the patients we've taken care of here, I think the program has kind of grown organically since we started. In our first year, we did 12 stereo EEGs. And then in this year, depending on how things work out with doing elective surgeries, we'll probably do 20 or so. But there's so many patients with epilepsy that would benefit from this type of procedure that I think the volume will continue to grow considerably. But it's really been even children who have previously had a grid surgery, we're able to go back and place these electrodes. And sometimes we find that we kind of thought we had an understanding of where their seizures were from the grid, but when we place an electrode deeper into the brain, we find that the reason they're still having seizures is because their seizure focus was actually deeper than where the grid was able to record from.
Well, that's interesting, because now I'm thinking, continuing to be impressed by my own ignorance about the way that the brain works and the way that seizures happen. And I'm just wondering, what is that cellular physiology, and what's gone wrong there? And can that be in a location, you remove that location, and now it's in an additional location? I guess I don't know that much about that.
Well, I think that's okay, because I think the reality is no one knows a lot about how about the natural history of drug-resistant epilepsy. And one of the reasons why it's so difficult to study is that epilepsy, by definition, is a functional disorder. And so we're really, my focus is on treating seizures, but the seizures can have very many causes. And so if I'm treating someone with seizures related to a brain tumor, often if I take the brain tumor out, the seizures will get better. And there's not a lot, there seems to be less potential for that tumor doing what we would call kindle the brain, which is where there's this idea that having seizures generates abnormal connectivity in the healthy brain that then causes the healthy brain to have more seizures spontaneously. And so brain tumors probably don't do that as much, but there are other things like focal cortical dysplasias or other types of seizure-generating pathologies that probably the more patients are having seizures, the more the brain changes and becomes susceptible to having more seizures over time. One piece of data we have to support that is that we know that if the longer someone takes to get from diagnosis of epilepsy to epilepsy surgery, the lower the chance epilepsy surgery will work for them. And that may be for a variety of different reasons, but one potential interpretation is that that's because of this kindling phenomena where the longer you have uncontrolled seizures, the more prone you are to having seizures in other parts of your brain.
Wow, that's my second wow of the broadcast. I will share that it's not uncommon for me to reassure families that seizures themselves do not damage the brain. And now I need to rethink that script, because it seems as though you could interpret this kindling, which is an interesting term that I'm unfamiliar with, but I understand where you're going with that, as a type of damage or change to the brain physiology.
That's right. And it's important to note that there's now evidence that it's not only the seizures that can potentially cause damage, but it's also the interictal electrical activity, meaning the abnormal electrical activity in the brain between seizures. There's a paper published maybe 5 years ago in Epilepsy that showed that interictal discharges are an independent risk factor for having a lower IQ. And so that's in patients that aren't even having seizures. They just have abnormal electrical activity because of their propensity for having seizures. And so having this abnormal electrical activity in your brain, even in the absence of seizures, can cause damage.
Wow. So, I feel like we're both saying wow a lot this episode.
Wow.
Well, it's pretty amazing stuff, frankly. So, Taylor, I guess, what you just said about the kindling, the rest of the brain becoming diseased, leads me back to my question about the other type of surgery you talked about. If children have broad areas of the brain where the seizures are coming from, you said that you can put in with deep brain stimulation to try and change the environment or the activity of the brain. How does that work, and how does it differ from what we've been talking about, where you really target a specific focus?
That's a great question. So there's been, in the last 20 years, there's been an emergence of neuromodulation technology, which are essentially these neurostimulators that change the activity of circuits in the brain to treat different conditions. And so the most notable example of this is probably deep brain stimulation for Parkinson's disease, or a central tremor, where you can turn a stimulator on in a part of the brain and really make a difference in someone's symptoms. And so that technology has now evolved to include drug-resistant epilepsy, but this is a very new area that we're still trying to figure out with regard to something like deep brain stimulation. So we're still trying to figure out which part of the brain is best to target to treat different types of epilepsies. The most tried and true form of neuromodulation for epilepsy is something called vagus nerve stimulation. And I think the truth is that nobody knows exactly how this works, but we place a stimulator, we implant this neurostimulator on the vagus nerve in the neck, and that is purportedly thought to influence the activity in these afferent fibers that go from the vagus nerve to the thalamus that then purportedly change brain activity globally. And so while I don't think we completely understand how this works, this is probably one of the most common procedures for epilepsy because about 50% of patients who have this procedure done will have a 60% reduction in their seizure frequency for whatever reason. And so that's often the first line neuromodulation therapy for children that have seizures where we can't determine exactly where they're coming from. But then there are these emerging technologies like deep brain stimulation and then also something called responsive neural stimulation, which is where we implant a neurostimulator that responds only to seizures. And we're trying to figure out how to best apply these new tools, but they've shown a lot of potential.
It's really remarkable, like the things that you're able to do and to make such a difference for, some of these children. And I really appreciate, I constantly feel like I'm humbled by medicine, and the longer I practice, sometimes I feel like the less I know. So I really appreciate your sort of caution about like, here's what we think we know, and that we can do things that help patients. And, you're helping these kids, even though we may not fully understand what we're doing. So I'm curious, how did you get to where you are, to this very specialized sort of area?
So like my personal backstory?
Yeah. In third grade, did you decide one day I want to insert deep brain stimulators into people with seizures?
So I actually thought I wanted to be a pediatric neurologist. And the reason for that was I actually had benign Rolandic epilepsy of childhood. And that's one of the most common types of epilepsy. But you grow out of it by the time you're in adolescence. And I had this wonderful pediatric neurologist, and I remember seeing the kids in his clinic that were, far more affected than I was, and just thinking, it'd be wonderful to do something where I could make a difference in their lives. And so I told my mom when I was 6 years old I wanted to be a pediatric neurologist. It turns out I'm much more of a surgeon than I am a pediatrician. And I ended up I actually tried to get into a pediatric neurology lab when I was in high school. And it just turned out that I ended up in a neurosurgeon's lab. And that's where my interest in neurosurgery really grew, and particularly my interest in research. And I think the idea of being able to cure someone's epilepsy by doing surgery really, really drew me in because it can be so life-changing. And that's what led me to Iowa, because they had a lot of NIH-funded research on epilepsy surgery for my residency. And then I think I already mentioned why I went to France, and then eventually to the Hospital for Sick Children, just because they have a very busy epilepsy surgery program, and then here.
Wow, that is wow number 4 for the podcast, Taylor. Record-breaking number of wow this podcast. I am so happy that we had the opportunity to talk with you today. I learned so much about what you do and about you as a person, which I really appreciate, and I'm really glad that we were able to arrange this time to speak with you.
Thank you. It was great talking with you.
Yeah, really great to have you, Taylor. Thank you for joining us.
I want to thank our listeners for tuning in. You can find other episodes of That's Pediatrics on iTunes, Google Play Music, and YouTube. Be sure to subscribe to this podcast to keep up with new content. Leave a review and tell us what other topics you'd like our experts to cover. Thanks for listening.